Hello everybody, and welcome to this session on left atrial appendage closure. So we have a super panel here today with Adele Aminian from Belgium, Livia Georgi from Spain, Lawrence Reber from Switzerland, Apostolos Tikas from Greece, Carsten Skog from Germany. And we are going to present and discuss some new options that we have with left atrial appendage closure. We want to look at the clinical data from the recently published large randomized option trial, LAAC versus DOAC, post-ablation, and we want to discuss also what is the impact of those data on clinical decision-making. And we will also like to present for you some new options regarding device technology. We will very soon have the Watchman FLX Pro here in Europe. So welcome to this session, and it will also contain a recorded case. This is from Bern, Switzerland, and Lawrence Reber will present the patient story here related to the case. So Lawrence.
Thank you very much. It's indeed my pleasure to introduce you to the case that we have pre-recorded and will present after two subsequential presentations. So this is about a 60-year-old female, 70 kilogram weight with arterial hypertension, hypercholesterolemia as cardiovascular risk factors. She has a complex history of peripheral arterial disease with a popliteal bypass for a thrombosed aneurysm, and that also underwent once thrombolysis and stenting, and she suffers from a recurrent iron deficiency anemia. She had multiple investigations. There is the diagnosis of a hemorrhagic gastritis, and there were also polyps identified. All this was treated, but nevertheless somehow the hemoglobin never came back to normal values. In December 24, she started to suffer moderately from a atrial fibrillation that was at this point in time newly diagnosed. As a side diagnosis, she had a bicuspid aortic valve, however, without stenosis or regurgitation, and her LV function is normal. The aorta is of normal dimension. Her chest VA score is 2 points, and her Haspel score is 2 points. And she's under aspirin and apixaban, valsartan, and rosuvastatin 5 milligram. Her hemoglobin currently is 95, normal renal function, no signs of heart failure. Treatment strategy for this lady is that because the AFib is symptomatic, a pulmonary vein isolation. This was done on the 4th of March 25 using the Boston Scientific Farapulse Farawave 31 millimeter system, and all 4 pulmonary veins were successfully isolated. The total procedure time was 51 minutes, and the therapy at the end of the procedure was continuation of anticoagulation with apixaban and aspirin. After the successful procedure, there was sinus rhythm. The second part of the treatment strategy would be a staged LAA occlusion using the Watchman FLX device at 21 days, mainly for reimbursement reason. We used the planning CT that was anyway obtained to plan the PVI, and the CT showed a cactus shape with a small proximal lobe. And when assessing the landing zone for the Watchman FLX device, we measured 19 times 14 millimeter and a mean of 17 millimeter. On top of that, that's in print, soon available in Eurointervention, but not yet, but nevertheless some first glimpse into a new score to assess the potential procedural complexity, as you can see here. And without going into the detail, there were certain aspects that are noteworthy. First of all, the distance to the pulmonary tip was 16, which is above 10 millimeter, which increases a bit the complexity of the procedure. But the key point in that situation was the limited working depth of like 9 millimeters. So that would limit the device placement. So ELAC score was 2, indicating a moderate complexity of the intervention. And that was the information we used for the procedural planning. There was no TEE planned prior to the procedure, but obviously then the procedure will be under pseudoanalgesia using TEE.
Thank you very much, Laurent. So this is actually a patient that will fit very well into the type of patients that was studied in the option trial. And Livia, can you give us some insights into the option trial results so we can take a closer look at this patient population?
I just want to introduce myself, Carsten Skog from Berlin, and wanted to give you the hint that you can ask questions online whenever you feel like it.
Good afternoon. It's a pleasure to be here and share with you an overview of option trial, and also to share some reflection regarding the role of the interventional cardiologist in the management of patients with atrial fibrillation and who are going to pulmonary vein ablation. The question is, why is so important option study? As you know, after pulmonary vein isolation, the anticoagulation is required. However, the anticoagulation may raise the risk of bleeding and also may have a negative impact on the patient quality of life. Later, we will see with the Apostolus that the adherence to the treatment is quite low, and that also may influence the long-term outcomes. Those concerns motivate to search a new alternative for those patients, so this is where the LAAC comes in. The option study is a multi-center randomized trial comparing patients with AF and indication for pulmonary vein ablation, which are randomized 1-to-1 to LAAC closure or to continue with anticoagulation. The primary endpoint was a composite of stroke, all-cause mortality and systemic embolism, and also the safety endpoint included major bleeding. The patients were in their early 70s. They had a high CHA2DS2-VASc score, low has bled, and also 40% of patients has a persistent AF. The results were encouraging. The efficacy endpoint showed similar results in both arms. There was a non-inferiority for the LAA closure in the closure device group. Moreover, we saw that the safety was demonstrated superiority in terms of bleedings, major bleedings. The same result present in graphics. As you can see, the primary efficacy, stroke, mortality, systemic embolism was similar in both groups. Moreover, the non-procedural bleeding was much more lower in the LAAC group, with a 56 relative risk reduction in the LAAC group. The secondary safety endpoint showed 23% of relative risk reduction in terms of major bleeding, including procedural bleeding for the LAAC group. If we look to the subgroup analysis, we can see that ablation plus LAAC is safer regarding the age, sex, CHA2DS2-VASc score, has bled, or type of AF. Moreover, there is an interesting aspect regarding the timing of the intervention, concomitant versus sequential procedure. In this study, they permitted to do concomitant or sequential procedure, and you can see there was safe and feasible to do both types of procedures. Finally, there was a success rate of 98.8% with a very low complication rate related to the device, 0.6, and a very low device thrombosis, 1.2. And speaking about the role of the interventional cardiologist, the Watchman study demonstrated a reality that we are seeing more and more in Europe, the high involvement of interventional cardiologists in the LAAC procedure and the key roles that they have in both concomitant and sequential strategies. To conclude, LAAC is a treatment option for patients with atrial fibrillation undergoing pulmonary vein ablation. It reduces long-term bleeding risk and also encourages collective flow forwards between the IC and EP. Thank you.
Thank you very much, Livia. We'll have time for discussion after the next presentation because you already alluded to one of the issues with medical stroke prevention, which is adherence to the therapy, and that is actually a quite large problem for those patients, maybe especially after ablation, because patients get sinus rhythm and they feel well, and will they really continue to take their DOAC? So, Apostolos, can you tell us more about adherence to medical stroke prevention?
Thank you very much. It's a pleasure to be here among this fantastic panel, and I like the fact that the session is well attended. So the introduction of the NOACs in the clinical practice was a revolution in atrial fibrillation, but unfortunately, no matter how strict are the guidelines and clear the messages, many patients are not treated according to the guidelines. And it's very good that we talk about randomized clinical trials, we talk about p-values, we talk about risk reduction, and this is all very scientific. I mean, in this room, it has been years and years of these discussions. But when we talk about stroke prevention for atrial fibrillation, there is an elephant in the room, and this is adherence. If we count 100 people in this room and you had atrial fibrillation, 30 of you would be unprotected for stroke right now. This is the situation right now. And the introduction of the new anticoagulants improved the field, but still the results are very disappointing. Even the patients that have more than 80% adherence, which is the metric, is less than 50%, and it goes down. And when the patient is not taking the medication, then he or she is unprotected, and then we have strokes. And why does this happen? Because the patient bleeds. They have bleedings. And it's very hard to convince a patient that has sequential bleedings to go back and take anticoagulation. And I will just briefly show you this paper, very nice study. 3,277 patients that were followed for 4 years with atrial fibrillation. 1 out of 5 had a new bleeding. And this bleeding was a major bleeding in 1 out of 10 patients. So this is a clinical reality. And I'm sure all of us, we face it every day in our clinical practice. So what happens when the patient has a bleeding? No matter how strict we want to be and we try to convince him or her to, go on, many of them discontinue drugs. And when you don't take a medication, well, it doesn't work. So major bleeding was the conclusion in this paper that was the problem. And we did a few years ago, we did a randomized clinical trial in Greece, actually. And we tried to increase the adherence to medication through interviews and interventions. We were calling the patients. And the study was positive. We were very excited that we reached 77% of adherence. That was the success. The rest of the patients were down at 55%. So left atrial appendage occlusion has one big advantage. You don't choose whether to take the pill or not. You either have the procedure done properly or not properly, whatever, but it's there. And so if we talk about adherence, I think we can beat the elephant. And then the elephant can have vacation. Thank you.
So, Livia and Apostolos, we have seen the option trial data now, a large trial comparing LAAC versus DOACs head-to-head. We have a very low ischemic stroke rate, 1.2% over 3 years. It's a little bit more, actually, with DOACs, 1.3%. But we have seen that there is much more bleeding among those treated by DOACs. And Apostolos, you have those data that probably around 50% of your patients will be off DOACs after their ablation. So have you now changed your clinical way of treating those patients after ablation? And are you offering them left atrial appendage closure. Livia, what about your institution? How have you?
So in our institution, the patients are coming from the electrophysiology side, and we are working door to door with them, and they saw that the therapy is function. We need to demonstrate them that that's function in these settings, and now we are thinking the patient twice, and we try to do the procedure, both procedure and concomitant, at least in my hospital, because it's how we are organized. And it's true, since the option results came, we did like 20 cases, option cases, in our institution.
And Apostolos, what about Greece? Is that something, will the EP send you patients for LAAC, or will they ask you to come to the lab and do a concomitant LAA?
The main barrier for concomitant is the reimbursement part, because the system doesn't pay for both at the same time. But I can share my experience from the ERA convention that was in Austria a few weeks ago, and the room was full, and everybody was very excited on our electrophysiology colleagues. And the main advantage and the main finding of option trial is that it shows in a randomized way that it works against NOACs, that the procedure works against NOACs. It's non-inferior for efficacy and superior for safety and bleeding. And this is the first time we have this data, so everybody is very excited. And now, whether we will do it combined or sequential, okay, that's important. But the most important thing is to have more referrals, I think.
Okay. Maybe I can ask another question to you. So if you had the chance, what would you do? Would you do it concomitantly, or would you do it sequentially? What would your preferred strategy? Because both were done in the trial, 60% sequential, 40% concomitantly, but what would be your preference? There are plus and minuses, right?
Well, I would do it the same session. I mean, we are there. It's important to do the imaging first, because there is some edema of the area when you do the ablation, and you need to study the anatomy very well. And in the majority of patients, I think this is going to happen. And by the way, I have been proctoring all over the world, and in 10 years ago in China, that was the standard practice, the one-stop shop. And we were still looking for data, which is good. Also in Australia, Karen Phillips was doing that. So I think at some point we will be more practical, and systems will understand that this is also cost-effective in the long term.
Yeah. So there's a question in the audience. If in clinical practice we have to give NOACs anyway after ablation, so why should we include the LAA? So after ablation, you have to give it for 3 months if you don't have any other indication for oral anticoagulation. And that's the advantage of the occluder, because you basically, with longer time follow-up, you collect all these bleedings with NOAC therapy. And we heard Apostolos talking about the NOAC adherence. So of course that depends on your bleeding risk. And we knew from the first randomized NOAC trials that adherence in these randomized trials, not high bleeding risk, because these patients were excluded, was 70 to 80%. So in the option trial, it was 85% because bleeding risk was low, ASPET 1.2, but you still see the bleedings, of course, in the NOAC group, and you see the efficacy of the LAAC compared with 2 NOACs. So really, really good data, and I guess we have to point out that that is the biggest randomized trial, LAAC versus NOAC, that was really well performed and really great results, or?
Yeah. Well, one last comment, just briefly. You can ask your electrophysiology colleagues in your hospitals on how many patients are on NOACs a year after the procedure, after a successful PVI. And no matter the guidelines, in many occasions, these patients stop the medication, sometimes with a let's say, acceptance of the electrophysiologist. But this is not clinically indicated. And now we have the option you have the option to treat these patients if they don't want to, in a concomitant sequential way, and then they are protected. And this is what the option trial shows.
Right. And you could even argue in both ways. You could say, well, we will have patients that are asymptomatic, but they have paroxysmal fibrillation. If they stop, then they are exposed to a high stroke risk. If the ablation is successful and they are on sinusin and they're taking NOACs, then they're bleeding more. So both ways, LAC is a very good option.
Adele?
Okay, Adele,
Finish the discussion?
just a short comment.
No, I just say
and we'll
it's
proceed.
I mean it's this trial is really novel because in my current practice, and I think in many centers, they were treating patient that has a contraindication, not really candidate for ablation. So this study is really dedicated to patients that are undergoing ablation and what to do then with the drugs. And this trial really shows that because the patient comes for symptom improvement for IF ablation, symptom improvement, and on top of that, you continue to give them a drug that decreases their quality of life after the procedure. And with even if it's minor bleeding, it's on the long term, it's very inconvenient for the patient. So this trial is really a novelty because, as you said, it gives you now an option that it's safe to get the patient get rid of this this hurdle that they get for the rest of their life, because they're a relatively young patient with long life expectancy. So taking the drugs for so long, I mean, it's not something simple.
Thank you. Let's come back, Lawrence, to your case. Patient with AF post-ablation referred to you for LAAC, and let's see how you manage this case.
Lawrence, can I ask you a question about that? Why do you give aspirin plus apixaban?
That was not me. It was not in our hands yet, but that was the decision due to the peripheral artery disease to add on aspirin, because there was also a stent, but clearly it's not indicated, and even more so as the hemoglobin was 95. That was the first thing we actually stopped, was aspirin. And then, as you said, we planned the continuation of apixaban. We had made a deal with the EPs to reduce it to 2 months, not 3 months. They were agreed on that to shorten a bit the DOAC exposition. We usually administer half dose heparin after puncture. This is the VersaCross sheet, which we pre-shape. That's really a good feature of the sheet, that it really keeps the shape we give to it. As you know, the aim is really very infero-posterior puncture. We go up in the vena cava with the sheet, pull the wire, and aspirate. Go up with the wire. We use the 2 planes. We slide down to the fossa ovalis. We are now very anterior. We move back posterior because we really want to have a good posterior puncture position and a good inferior position. Here we are not bad. Huh? Okay, now we approach with the radiofrequency wire, and if we push a bit, we give the signal now. Yeah. And we cross the septum in a very, very controlled fashion. The next step now is that Dr. Bruger is now verifying the wire position. He confirms that the loop of the wire is indeed in the LA, which is nicely seen here. The next step is a pre-dilatation of the puncture site with...
You're in the pulmonary vein now.
Yes, excellent. Pre-dilatation of the transeptal puncture, and then the next step is already the insertion of the sheet. Meanwhile, we will have a look at the morphology by TOE.
Here I am aligned with the side where we are going to land. I evaluate on the green plane about the same. And then going in the middle, I will just make a spin to be sure. You can look at the green plane that everywhere we are good to land. So this should be good. Then we go back to the home view. And here we can see it is the part where we'll have the very few deaths. So it was measured about the same as in CT, 11 millimeter. And the size would be, it's a bit smaller. That's what I measured before. 1.6 to 1.9 centimeter for the landing zone.
The landing zone has a maximum diameter of 19, which is fully aligned with the CT, which is always good if the two modalities are in alignment. If this is not the case, we have to find out what the reason is. Maybe the hemodynamic conditions are different. Of course, the most frequent reason will be that the landing zone is not assessed at the same region. So we have to really dive into the multimodality assessment once again if we have discrepant values. Not the case here. We now enter with the Watchman sheet. As we pre-dilated, this usually goes very smoothly.
And the nice thing here is that this guide wire is already stiff enough to use it directly.
Exactly, we don't need to change. That's very elegant. We know from the TOE that we are with the loop of the wire in the pulmonary vein. We now move forward with the sheet over the dilator and remove the dilator. Now we flush the sheet. The nice thing, of course, about the sheet is the well-working hemostatic valve, which really facilitates the flushing. Now we enter a pigtail. Once we are inside the LAA with the pigtail, we slide with the sheet over the pigtail and then verify the axis in the TOE. Now we have a look at the TOE. How far are we with the sheet? Position is pretty good. We are coaxial and actually ready for the device. Now we're going to prepare the 24 Watchman device. Yeah. And we do routinely a short angiography in a RAO position, small test. Yeah. Ready?
Yeah.
Go. So for the device, we actually move a bit back and forth and then align it with the marker. Then flush first the Y piece. We obstruct and flush it back. Maybe we have to move again a bit. Yeah. We flush the Y piece and then we flush antegrade a few times back and forth so that we avoid bubbles in the system. So what we do now is we open the sheet, the valve, and flush and enter and close again. That's really the nice thing about the Watchman sheet, that there is absolutely no risk for air embolization. We advance, marker over marker. Get a bit back, marker over marker. Yes, now we align the axis according to TOE. So like this is not bad, huh? We form the ball. As we are deep, we rather unsheath than push it out, and then see where we are. So that's not a bad axis. I think the position is a good one. We slowly unsheath. We push a bit for like 20 seconds. And the next step now really is the assessment of the pass criteria.
So now we will do the final assessment of the LAA occluder. So first compression. So it is a 24 device. So here on 30 we have 20. It's really good. So I go up
16%, that's perfect.
To 60. Here we have compression of 21, which is also excellent. So to 90.
So what Nicolas basically does is he looks at the 4 planes, assesses the compression, which should be somewhere between 10 and 30% approximately. And that really seems to be the case. And of course, we also assess the P of the pass criteria, which is that the device is gently protruding over the ostium, which is also the case. And here we want to have a particular attention to the lobe, whether the proximal lobe that we have discovered already by the CT and is confirmed here by TE is covered, and that seems to be the case. So this is really an ideal position with a very good compression.
So the maximal compression is 19 and the minimal is 21.
What is lacking is the exclusion of a residual leak with particular focus on the region where we have the lobe. And finally, the additional criteria stability, so confirmed with a TAC test that we will do in the view that is most critical for the device stability. Okay, so why don't you go in the biplanar view and we do the TAC test? You tell me when you are ready. Okay to go for the TAC test?
Okay, that's good.
Yeah. So we open the valve and give it a tug. So the pass criteria are actually fulfilled, and we all agree to release the device. You agree,
Yes,
Loro?
I agree.
Nicolas?
Yeah, that's good for me.
So let's release the device. Of course, we could do a final angio. However, if we have such a good imaging quality by the TOE is actually not really needed, and we really want to simplify the procedure. That's why we do a pre-procedural and a post-procedural occasionally if we have any doubts, which is not the case here in view of the very nice image quality. Thank you so much, and have a good Congress.
Congratulations, Lawrence, with a very nice case. It was not easy. It was a shallow appendage. Depth was only down to about 10. You actually had also proximal trabeculations, and you have hypercontractility of the appendage, but a very nice result. So this was done sequentially. But one other option could be to do it concomitantly. So in your understanding, what would be the best, which strategy do you like to follow, concomitantly or sequentially?
So basically, patient first, and for the patient the answer is clear, he wants to have all in one shot. However, what we need to acknowledge is that the team now is expanding to the electrophysiologist, and depending on their degree of experience, they want to keep the procedure safe. Option has uniquely demonstrated its safety. However, once you start a new program, you need to prove that you can do it safely, otherwise you will not get the referrals. So the key to maintain safety would be that in the CT that you get before the procedure that is done anyway for the prior to the PVI, to plan the PVI, you assess the complexity of the procedure. And if you deem it a complex procedure, you may occasionally consider to do it in a stage fashion. If there is a straightforward morphology, it's certainly the best for everyone to do it right away, because as you have said, you have experience of like 10 this year. We have the same. It takes you 10 minutes more if there's a straightforward morphology, and there's no reason not to do so. And with increased experience in the entire team, you probably the fraction of patients you're gonna stage will come down every year.
Lorenz, one quick question from the audience. You did not use a BRK needle. What is the option that you have for transeptal?
Yes. So we actually changed recently. We did the last 500 procedure with the needle, and now switched to VersaCross. And I must say, we tested it in 10 cases, and after that we completely switched. So we abandoned the needle because we made a calculation for the budget. It's actually cheaper. And second, it's much more controlled. As you have seen, the moment where you penetrate the septum is a very, very controlled one because of the radiofrequency signal. And this really allows you to get a very, very controlled puncture. And that's why we changed
Lorenz,
to...
how is it cheaper?
So it is cheaper because you have to calculate everything. So you need, usually we use the stiff wire. That you don't need anymore because it's in the package. We usually use the multi-purpose, and the needle is, well, I'm talking about Switzerland, is like 350 Swiss francs. So if you calculate everything and you get a certain amount of the VersaCross, then it's cheaper.
Good to know. There is a question. Can you go to the microphone?
Thank you for the mic. So I'm from the US. I just want to explain to you, the video you presented is the technology we used 2 years ago. Right now we switched to the TrueSteer technology, and the VersaCross is a standard of access for us. So the question is, the cost in Europe is higher than can justify the conversion into the TrueSteer shear and the VersaCross. For us, VersaCross is a very safe technology. It's very efficient. The procedure takes more than 20 minutes to be done. I just want to see what's your experience here in Europe.
It's not available yet. We are a little bit behind, but we use VersaCross with the sheet as well. And it's really good, and it's just safer for the patient because you save a lot of time and procedure.
And we really look forward to get the TrueSteer sheath. I mean, that can really, I think, improve our implant results, especially if you have a very anterior-orientated LAA. It's with the current sheets, it can be difficult to really obtain coaxiality and implant the device perpendicular to the landing zone, and that's something you can do with the TrueSteer. So I really look forward to have that option. I think it can reduce leaks with this sheath.
Another quick question from the audience, Nils Erik, for you, because you included a lot of patient in option. So if you do it concomitantly, where do you puncture the septum?
Yeah, the way we did it for the option trials was that I did the transeptal puncture for my EPs, actually, because I wanted to go inferior and posterior. So I was there in the beginning of the procedure, and they were quite okay with me going inferior and posterior. Then they took over, did the ablation case, and I came back and did the implant of the Watchman. So that was the way. So, but they were not unhappy with the way the site we used for.
Yeah, and this is an important technical question. Is it a problem? I'm not an EP. Is it a problem from an EP to have to do an ablation with an inferior and posterior puncture? Is it a problem or not? I don't know.
No, it's not.
Apparently, it's not.
It's not. We routinely advise to go inferior-posterior prior to the ablation, and it's not a problem.
So that makes a concomitant procedure quite feasible, yeah? Okay.
I have a question here. I'm Pablo Esparta from Argentina. So I want to know if, for example, this anatomy, that is this shallow anatomy, the edema of the ablation could be a problem in the concomitant interventions.
Yeah, that's a very, very good comment. And with PFA, you do get, and also with radio frequency, you do get edema of the pulmonary vein ridge, and in some situations it can be quite prominent, and it can represent a problem. And also, I think if you really want to go for concomitant procedures, you need to do sizing before actually that you do the ablation. Otherwise, you'll get smaller measurements. But I know about cases where the swelling was so pronounced that they actually had difficulties in getting the device in. So it is an issue. And having a sequential approach, you will not face that problem. But I think it's very variable. In many cases, you don't see this swelling. So, but it is an issue.
You should measure before. That's important to know.
Okay, so one of the things with left atrial appendage closure is definitely the anatomical variation that we face, and it can give us certain challenges. And Adele, you are going to tell us about this and also a new way of predicting complexity for a procedure.
Thank you. So these are my disclosures. So it's something important. How can we define the complexity of a certain LAA anatomy? I think we have to move away from this shape-based classification with cactus, cauliflower, because it doesn't tell anything about the complexity of the case. That's what we have attempted to do with this European classification, which was part of a consensus between many operators and also was presented during the first European LAA meeting. And we have defined very simple and I think things that people can understand about the complexity of the procedure. It goes from the entrance, the ostium, to the landing zone, to the overall anatomy, to the axis of the appendage, to the fact that you have a hypercontractile appendage. All these parameters, which now have a clear cutoff, have been presented, and we will try to promote that in the future, because it makes sense that if you have, for example, a large entrance, if you have a very prominent pulmonary ridge, if you have a low takeoff of the appendage, if you have very high eccentricity of the landing zone, or a very early sharp bend, which is very close to the landing zone, that will create some issues. And we have tried to understand what will be the consequence of each parameters. And I think many of them can have clear consequence. For example, if you have a very hypercontractile appendage, you increase the risk of embolization. If you have a funnel shape or a very highly eccentric appendage, that will create a lot of issues with the sizing, and you can end up with some complications like per-device leak, or in some of the parameters can increase the rate of device-related thrombus. But what I want to focus here is about the large anatomies, because that will be a transition to the case of Jens-Erik. But if you have a large anatomy, like a large ostium or a large landing zone, that create probably some issues with the complete sealing of the appendage, and the risk is to have a per-device leak. And just to say that because Lawrence has talked about the score, but I think, of course, if you accumulate many of these parameters, for example, you have a patient, like he has shown actually, you have a large ostium, you have a short depth, you have an early bend, you have a very highly contractile, in the same patient, that will really increase the complexity of the case as compared to another one. So if you have a large ostium, that probably will create some challenges. And the one is very obvious is the risk of undersizing and incomplete coverage of the appendage. So that can create instability of your device, probably embolization if you really are super undersized. It definitely increases the risk of significant per-device leak, and it can lead also to procedure failure because you don't have the size available for a certain anatomy. And it has been shown in the past, when you have this study from Jackie So with the CT follow-up, that if the device is less compressed, so probably undersized, you increase the risk of having patency on CT follow-up. This was shown with the Watchman, and this was also shown in this study with the ACP amulet from the group of Jens-Erik, showing that the more the device has a good amount of compression, the more you decrease the risk of peri-device leak. This is shown here, and this was an independent predictor of CT patency during follow-up. But you see also that the orifice diameter and the landing zone diameter for the amulet was also an independent predictor of patency, of residual patency and peri-device leak at follow-up. And that's where there is an advantage of having the availability of larger LAA closure devices, and this is something that we get now with the new 40 mm Flex Pro that really allows you to treat landing zone that have a maximum diameter of more than 31 mm. With that in mind, you get a better compression, and also you are not forced to place your device more distally to seal the appendage, because then you really increase the risk of proximal thrombus on the device. So just as a conclusion, I think that now we need to go beyond this classical and traditional shape anatomy. We need a more structured approach to assess the anatomical and functional challenges of our LAA closure procedure. By understanding all these parameters associated with complexity, I think the operator can better prepare himself and potentially decrease the risk associated with varying LAA anatomies. And by this way, you improve the procedural and long-term outcomes of the patient. This is our main goal as an implanter. So thank you very much.
Thank you very much. Thank you very much, Adel. There's a good transition for Jens Erik's case, who will show us how to occlude a huge LAA in a patient. And I wanted to take some seconds to ask, how many of you are in LAA closure? So how many did at least one case from the audience? Could you raise your hand? Okay, so 60%. Okay, thank you. Jens Erik?
Thank you, Carsten. So this will be the next iteration of the Watchman FLX device, the Watchman FLX Pro. And first of all, as Adele already have said, one new feature is that we have this device in an expanded size range. So we have now the 40 mm device allowing us to do appendage closure in landing zone diameters up to 36 millimeters. But it's not the only change, because there's also a new fluoropolymer coating to the fabric membrane here. And this was engineered in a way so there's more thromboresistance to it. And there's also, in animal models, more rapid ingrowth of tissue and endothelium across the device. And everything is with the thinking that we have to minimize post-procedural antithrombotic treatment, because we are treating patients with a high bleeding risk. There's also a very nice new feature on the Pro device. You can see that there are 3 radiopaque markers here at the level of the device shoulder. So that's something that helps us to get a very precise landing of the device. I have had, the Flex Pro will actually reach us in probably June, July here in Europe. It's already routinely used in US. I had the opportunity to work with this device quite early as part of a trial where we looked at the Flex Pro device, and we did serial image very early on after 14 days, 45 days, and 3 months. And this was one of the first patients in our Flex Pro CT study, an 81-year-old man that came with a clinical indication for LAAC. He had a low platelet count, a prior DDD pacemaker, and he even previously proved the risk of having a LAA thrombus that was diagnosed 6 months before, and we had to put him on low molecular weight heparin. But he was enrolled in the study, came on the procedural day with a low platelet count. We had to give him platelet infusion, and this was the pre-procedural planning, and you can appreciate a very large LAA in this patient here. And you can also appreciate that there is a filling defect in the peripheral part of the LAA. And this can, as you know, be difficult to discriminate. Is this real thrombus or is it slow flow? And this pre-planning tool, the TruePlan, Watchman TruePlan software, allows you to follow 2 different sequences of the CT scan, scroll up and down, and here you can see there is a difference. This is the early scan, and then we do a little bit later, 3 seconds after, a delayed scan. And this is not entirely the same. There's a little bit more attenuation, and it's not so well defined. Anyway, we did a supplementary TE and did rule out that this was real thrombus. So this is again the pre-planning with the Watchman TruePlan software, and you can see that the maximal diameter here of this appendage at the level of the circ, where we want to land the device, is 35 millimeters. Perimeter derived 32, so this is a very large appendage. And as Adele already said, in some cases we might go just a little bit more peripheral and then close with a 35 millimeter device. But you can see this LAA here keeps this dimension of around maximal diameter around 35 millimeters quite distal here. So this was a very good case for the 40 millimeter device. And you see the Watchman sheet, and you see the selective LAA angio in this very large appendage. And totally the same with the Pro device. You start with the flex ball, and then in this case back sheeting, and then you can follow where the markers land. That's the level of the shoulders. And on the left-hand side, you can see tucking of this device. And you can see the control angio here on the right-hand side. And you can actually see that the radiopaque markers is not fully aligned here. So that means that my C-arm view is not totally perpendicular to where I landed the device. And it helps me because you can, that will be the next here. You can then just move your C-arm. So now you can see that I have all the 3 markers aligned here. And then I know I'm perpendicular, and this is optimal. If you have a little bit of shoulder protrusion, I will go one back again, which you have in this case, I know that I'm completely perpendicular, and I can really more precisely evaluate my degree of shoulder protrusion, which is less than 1/3 in this case. And this is the final release of this 40 millimeter device. And as part of the Flex CT Pro study, this patient came back. This is a early scan, or actually it's a second scan after 4 weeks' time, and you can see that the appendage is fully occluded. There is a little bit of hypoattenuated thickening on the device, which completely resolved on the 3 months scan. So actually, we had 50 patients in this CT Flex Pro study, and I used 5 of the 40 millimeter device, which is a quite high rate. I will say that the radiopaque markers are helpful. They help you in optimal landing of the device where you plan to land it at the level of the circ. It's useful when you tuck the device. You can see that the markers come back to exactly the same site if you have stored your fluoro. And it's helpful if you want to evaluate the shoulder protrusion as well. And regarding the fluoropolymer coating, actually in this small series of 50 patients, we only had single aspirin as a post-procedural medication for those patients. And there's now a large study undergoing more evaluation of this concept in US, where the Flex Pro device is compared with 3 different post-procedural regimens, either single antiplatelet, dual antiplatelet, or low-dose DOACs. But it's, in theory, it should allow us to come down in the level of antithrombotic therapy with this new device. So thanks for your attention.
Thank you very much, Jens Erik. A really interesting case, although, to to our US visitors, that's not news. We are looking forward to receiving the device. So you mentioned it, single antiplatelet. What's your, in clinical practice, most common used antiplatelet strategy after implantation with in general, I would say, yeah.
Yeah, it is actually to use SAPT. And I think if you look back on the data, I don't find that there is a significant advantage of dual antiplatelet, but there's a clear tendency in the data that we have available, which is not randomized, but that you get more bleeding if you put patients on DAPT. So I really, really look forward to the trial with the Watchman FLX Pro, where you look at SAPT versus STAP versus low-dose DOACs, because I think that's the three regimens out there that can be relevant for the future.
Yeah, and I mentioned that because there's another question soon. One question from the audience: what was the strategy in OPTION? In OPTION, there was a strategy of 3 months of DOAC plus aspirin. Aspirin should be continued for the trial, or at least for 1 year. So that was the antiplatelet strategy, or the post-implant therapy in OPTION.
I have another question. So after the learning of that the dots of the device can show you the perpendicular alignment with the ostium, the shoulders of the flex are pretty visible too. So do you think that we have to change our planning for the implant of the device, and we have to look for the best implant view like we use for TAVR or something like that?
I certainly believe that that's a way to go, and that's what we normally do when we pre-plan on CT. You could argue here that I was not very successful because my first C-arm position didn't capture the exact alignment of the 3 dots. But if you normally if you pre-plan it, you will also get your first C-arm position to be successful, and you'll see the 3 dots aligned. Yes, I think it's a big advantage that you are exactly perpendicular to the device when you evaluate the shoulder. And I mean, we can accept up to 1/3 of shoulder protrusion, but I like, of course, to have it as much inside the appendage as possible. One thing with the 40mm device, I was really impressed by the technology, that it doesn't feel that you have a lot of resistance, and you can deliver through the same size sheath as all the other sizes, and you can also recapture, and you don't feel that the recapture forces are needed to be much higher. So it's you can really just go on from what you have learned with up to the 35mm device.
You don't have any much more like they pop out, for example?
I think the first time you deploy the device, you will get a little bit surprised by the length of the device. It's really, it keeps coming out when you backseat. But it's a very fine device, and it's very nice to have this option now to close large LAAs.
Thank you.
So maybe for the panel, one last question from the audience. What is the indication to occlude the LAC after ablation? Is it only high bleeding risk?
Or? Well, for the moment, we're not treating the option patient. We're treating a patient that undergoes ablation and then has some contraindication to long-term oral anticoagulation, and this is the patient that we treat. But right now, with this indication, I want to make this comment. The potential candidates in the European area, the broader European area, is 1 million patients. And if the Champion AF study has positive results in less than a year from now, this will explode to 10 million potential candidates. So the patients are there that may benefit, and it's our responsibility to share the data, whatever we have, with you and you with others, to make this available.
I think there will be a gradual implementation of this of those trial results, and as the question alludes to, also my EPs, they look at the patient, and if there has been any, minor or major bleeding issue, that's much easier for them to send them for LAA closure, and that's the patients that we consider now. But in reality, we have firm clinical trial data also to treat patients that have not an exaggerated bleeding risk after ablation.
Right, and that is really important to point out. It's not only high bleeding risk, because for these patients we have a 2BC recommendation. This is basically everybody who comes to your department with a Chance-Mask or Chance-VA larger than 2. And the patient can decide whether he wants to take the medication or get the LAA occluded, and the data are there. He will bleed less and he will have the same stroke prevention.
So, Carsten, can you please go to the podium and wrap up and give us the take-home messages from this session?
Yeah, I guess we had a nice discussion. We could not discuss everything, but basically we showed the data that we have new options for LAAC, not only high bleeding risk patients, but patients post ablation. And I want to point out again that the OPTION trial is the largest RCT to date, with 1,600 patients, and in follow-up of 3 years, that showed that LAAC with Watchman FLX was compared to DOAC therapy. And we have now the results that the LAAC over these 3 years is non-inferior in stroke prevention. It's the same efficacy as a DOAC, and that is superior in non-procedural major and non-major clinical bleedings. And if you take the procedural bleedings into account as well, then there's still a significant advantage of LAAC. So basically, we can conclude that the LAAC with the Watchman FLX is safe and effective, and it is an option for patients after AF ablation, and we can do that concomitantly. We talked a little about that, or we can do it sequentially in the lab. And then we learned that for the European market, the Watchman FLX Pro will come in July, and with another sizing, the 40 millimeter device that can include LAAs until ostium size of 36 millimeter. And that is coated, and that's a Pro to reduce the risk for DRT, and we will see what the other studies show, whether we can reduce the antiplatelet therapy, the post implantation therapy. So, and I guess we are in time, a little bit over time. Jens Erik?
Yeah, but I would just want to thank you for coming, and thanks for your attention. I think we can close the session, and hope you will think about going home to your labs, think about the option patients, and expand your volume of LAACs. So thank you for coming.